is the coding improvement program, which is why I've been asked to come along and present to you today. So I will share my presentation with you. If anyone has any questions as we're going through, please feel free just to shout out or to stick your hand up. Becky's kindly agreed to monitor the chat for us, just 'cause it's quite hard for me to keep an eye on both while I've got the slideshow going. But yeah, there's absolutely no problem with you just shouting out if you've got questions. So then, let's crack on. So the first thing I think we need to sort of get into the weeds of when we're talking about the role of clinical coding is the question that comes up all the time, and the question that I'm asked sort of most often, and that is, well, what is clinical coding? And it's a difficult one to answer because it's quite hard to explain when from a position of not knowing anything about it. It's a really hard industry to get into and to get to grips with because there's not a lot of information sort of easily accessible from outside of a clinical coder's perspective, which as an industry, that's kind of our fault. It makes us very, very insular. And sort of the bigger part of that problem is that this is the definition from our own source materials. And I won't read it all out, but it's a really stale textbook definition. And sort of when that's the language that you're trained with as a clinical coder, you can't even describe what you do to your friends because they just glaze over. My own mum still doesn't understand what I do. So when we answer the question, what is clinical coding, with this answer, asked another question. So what is clinical coding? Because that really technical explanation from the previous slide just doesn't answer the question. It's a lot of words that doesn't really make it any clearer to anyone. So if we break it down into sort of the key parts, and hopefully you'll get a better understanding, an idea of what actually clinical coding is. So it starts when a patient gets discharged from hospital. They'll have an admission on the trust's PAS, the patient administration system, and that's sort of how the patient is moved through the hospital while they're an inpatient, if their appointments are scheduled, and it's also where the coding takes place. So that admission will need to be coded after the patient's gone home. So they go home, and the patient's record, whether it's the physical case note, if you're still using paper at your trust, or whether it's the digital documentation, if you've got an EPR, or a hybrid of both, which a lot of trusts use at the moment, they'll be reviewed by the clinical coder. And all that information is sort of looked at, and the coder will extract the relevant diagnostic and procedural information from the records. They'll analyze it and select the appropriate ICD-10 and OPCS4 codes. So that's sort of what coding is. That's what we do. The how we do it is the other part of the answer to the question, really. So we're looking at all that information, we're reading it all. We then have to translate the medical terminology using the ICD-10 codes that I spoke about in the last slide. That's the diagnostic classification, and then OPCS4. We're currently at version 4.9. 4.10 is coming out in April this year, and that's the procedure classification. So we then get the appropriate clinical codes from those two classifications. Once we've got all that, the next step is checking everything that we've found against national coding standards, any local coding policies that we've got, and we make sure that the codes we've got are correct, and there's no rules or sort of notes indicating you go to a different code. So when I talk about translating medical information, what that means is taking all of the medical jargon and the synonymous terms and clinical abbreviations and cutting through that and assigning standardized and uniform alphanumeric codes. And that's sort of the really important part of what coding is, because that gives us a usable data set. So if we take an example here of a heart attack. So we've got 3 different ways that you could write, or you could see written in a case note, a heart attack. It could be documented as any of those 3 terms, but actually the code assignment will be the same. It'll be that I-21.9, and there's some variations if there's specific information about the MI, but if we just say it was an MI, that's the code that we're going to get. What's really important about that is it makes your coded data comparable across trusts nationally, and you can also compare it internationally if another country is using the same classification. So that's what coding is, and that's why we do it, and what the outcome is at a sort of data level. So we've got all those clinical codes now. We've read everything, we've got it. We then enter those codes into our relevant PAS system, whatever you might be using at your trust. That data is then processed through the grouper logic, and that will apply a tariff. And that tariff is in line with the national tariffs, and then any locally agreed contracting arrangements that your trust might have with the commissioners, which we'll come on to a little bit more detail in just a minute. So that's the process of what coding actually is, and hopefully that gives you a better sort of grounding and point of reference of what we mean when we're talking about clinical coding. It is a very manual process. You have a human sat there with a case note, reading all that information that a clinician has written while a patient's been in hospital, and determining what's happened and what was wrong with them, what treatment was delivered, and then taking that knowledge and applying the clinical codes from the classifications books. So how does clinical coding drive clinical income then? So I mentioned in the last slide HRGs, so we need to sort of understand HRGs as a starting point for looking at clinical income. So what is an HRG? So an HRG is a health resource group. There's just over 2,000 admitted patient care HRGs and 235 outpatient procedure HRGs, which I'll explain what that means in just a second. So an HRG is groups of clinically similar diagnoses or procedures, and they are similar in the sense that they have a similar resource implication, so that they can be basically grouped together by how much it costs to deliver that care, or how much a tariff should be applied, what the value of the tariff should be applied to them. They are derived by all trusts across the country submit reference costs, and those reference costs are reviewed and averages are taken, and the tariffs are arrived at by these averages. And then it's a tiered structure. So because there's obviously differences in individual patients in terms of how complex they are as an individual to treat, due to comorbidities and things like that, and age, it doesn't make sense to say, well, here's just one tariff for that one HRG. Actually, know that the majority of HRGs are then broken down into further degrees to have different tariffs assigned to them depending on the complexity of the patient being treated, to take into account the greater needs of a patient while they're in hospital. So as I said at the beginning, there's 2,303 APC, that's admitted patient care HRGs. There's a short list of outpatient HRGs, and so clinical coding doesn't deal with outpatients, and outpatient appointments are given a first attender fee or follow-up appointment fee. That's how the tariff works. However, if a procedure is carried out on an outpatient basis, most HRGs across the board are procedure driven. So as soon as there is a procedure put in, they will tend to shift to be a procedure-based HRG rather than a diagnosis-based HRG. And what there is in the vast table of HRGs for APC, there is a column which includes outpatient procedure, which basically means if a procedure that qualifies is carried out in an outpatient basis, it will hit the outpatient procedure tariff in the APC HRG table, rather than that flat first attendance or follow-up appointment for outpatients. So it's just worth keeping that in mind. If you're ever having to look at HRGs and sort of provide information on HRGs, it's worth knowing that if it's outpatients that you're looking at, you may need to look across at, is there a procedure carried out and is this a procedure driven HRG? So in terms of how HRGs underpin the NHS payment infrastructure, that's changed a lot over the last few years. So up until, well, we'll go back a bit further actually. So many years ago, before I started coding was very much a back office function, and clinical coding wasn't used as a marker in NHS income. And then payment by results, PBR, came out, and this revolutionised how the NHS payment model worked, and that brought clinical coding right up into the fore, so everyone could see what was happening, because clinical coding drove income, and it was the easiest thing to point at, particularly if things went wrong. So payment by results is pretty much exactly what it says on the tin. You get paid for the care that you deliver, and that's where HRGs really sort of come into their own. So your clinical codes drive your HRG drives your tariff. So services will have expected activity levels and expected income levels, and they will expect certain HRGs for certain care that they deliver. So it's very easy for them to track if they're getting it or not. It worked for a long time. It's not a perfect model because HRGs aren't a perfect model, so they're really good at what they do, and there's a lot of infrastructure behind them and underpins them. But like I said, they're taken as averages from reference costs. So what that does is create a little bit of a discrepancy. So if Trust A submits costs that are significantly higher than the tariff for a certain procedure or a certain bit of care that they deliver at their trust, they're less likely to carry on delivering that service because the tariff that they're achieving is significantly lower than what it's actually costing them to do it. And so there's two things sort of that can happen here. Either a trust deprecates that service, and that's sort of got a knock-on effect on their local community. If it's a service that can't be deprecated, and what happens more often though is they will approach the commissioners with a comprehensive business case to say, actually, no, could we have a local agreement, a local contracting agreement for this type of activity, because we can demonstrate that although it costs us even more than the HRG to carry it out, our recovery rates are lower, our readmission rates are lower, our lengths of stay are lower, and our overall patient outcomes are better. So yes, it costs more, but actually we're doing a better job of it, so we deserve to continue to deliver it at that level. Likewise, the other side of that coin is that it might start creating money hand over fist for a trust to deliver a service. So they could increase the volume of that activity, but that will usually be at the expense of something else, and that again could have a knock-on effect on the local community. So yeah, it's worth just keeping in mind that it's not a perfect system, and that's kind of the purpose of local contracting agreements. So that's where we were with PBR. When the pandemic started in 2020, that stopped working. Really, it wasn't usable. There wasn't a way to monitor COVID as in terms of HRGs. There wasn't an HRG for it that was sort of appropriately applicable to the level of care being delivered and the amount of resource, because it was too new. It just wasn't calculatable. And the impact on activity levels just meant that PBR wasn't sustainable. It wasn't the right model to use. So instead of having this, it also creates a focus on specific activity, and that wasn't appropriate either during the pandemic. So what PBR was suspended during COVID-19, and initially everyone was put onto block payments. So a block contract is usually what happens in ED departments, and that's, here's a block of money. This is appropriate to usually what it costs to run your service, and that's reviewed at regular intervals. So everyone was put onto block contracts across the board based on their activity from sort of the previous couple of years. And that's how we went through the pandemic until 2021, I think, when there was a lot of sort of media coverage and a big spotlight on the elective backlog that had grown during the pandemic. And now, as the pandemic was sort of slowing down, there was this huge elective backlog that, how was the NHS ever going to recover? So the next model that followed was the elective recovery scheme. What elective recovery was everything non-elective remained on block contracts, and most elective activity shifted back to a PBR model, and that was to encourage trusts to increase their electives and clear that backlog, because they'd get the sort of the more appropriate funding and likely more income but than they would from their block contracts. And then since we've sort of come out of the pandemic days and we're trying to build afresh, what we've started with in this financial year was the aligned payment and incentive program. So that is quite complicated to explain. The majority of care stays on block contracts, and trusts have got scope in how they want to deliver it and how much they want to subscribe to it. But there's an incentivized level. So a trust has an activity plan and how much elective activity they expect to do. Anything under that plan, a trust is what's the right word? Not fined, but there's a penalty of 80% of the value of the HRG for that care that they have to basically pay back. And if they overperform their electives, they are given 80% of the HRGs for that overperformance of activity. A lot of trusts chose not to subscribe to aligned payment and incentive. I think a large part of that factor was the 80%. It didn't seem fair to a lot of trusts. So a lot of trusts have carried on with the elective recovery model across the Northwest. That's certainly the case. Our trust, Manchester Foundation Trust, when this came out at the start of this year, we were sort of in the build phase of our new EPR, which went live in September. So given the scale of that transformation project, the decision was made that it didn't make sense to have a huge change in our financial infrastructure at that time. So we kept it the same as the elective recovery sort of approach. And then, for what it's worth, there is talk. They've not finalised what the approach will be in the next financial year, but there is talk going on that we'll go back to payment by results to tackle the elective backlog that is persisting. So time will tell where we end up to. But across all of those models, the key thing is that HRGs underpin it. It's all driven by the HRG logic, which is then driven by the clinical coding at the heart of it. So to varying degrees, the coding is more or less important, but it's always there driving it in the background. So this is my friend Rex, and this is a representation of the HRG grouper and how HRGs are made. The grouping logic is actually really complex. It's a fantastic computer program, but the simplicity behind it is that it's a sausage machine. Information comes in and HRGs come out. So it starts with the admission method and length of stay. Length of stay is important because it's got trim points. So each HRG has an expected length of stay. And there is then associated with that a trim point, and the trim point is an additional payment per day for every day that the admission goes over the expected length of stay. What's important to remember about that is it's deliberately designed to be less than the cost of a bed for each day. And that's to avoid trusts sort of capitalising on long lengths of stay to get the trim points. The trim point deliberately, it's money towards the cost of the bed, but it doesn't cover the cost of the bed. And then the word of caution about that approach would be the next patient that takes that bed could have a significantly higher HRG, depending on what they're admitted with. So it's not really a viable game to play the length of stay game, but it is accounted for in the logic. And then the primary diagnosis, any comorbidities and a procedure, so that's the coded data, goes in next, and then outcomes at the end, an HRG. So all that information drives your HRG. The HRG has a tariff associated with it, and those tariffs then drive safe and sustainable clinical services. Now, this safe and sustainable clinical services is quite important. I'm going to come back to it in a couple of slides' time, so just remember that bit. So the case mix of the HRGs, so as I said, there's a tiered structure. So there's 2,882 HRGs in total, and of that, 1,800 are tiered. So they're the ones that take into account the different levels of complexity for patients, and only 1,000 are static. So it is across the board. The majority do take into account that patients are more or less complex. And this is just a quick diagram of how that works. So if you've got a primary diagnosis, you'll hit your base HRG, which is the minimum income. However, once you start adding comorbidities, you start getting paired and tiered HRGs, and that's always going to have an escalated income. So we're now going to move on to comorbidities, and you'll find that I harp on about comorbidities an awful lot, because when we're talking about HRGs, comorbidities are really where the battle is lost and won, because they're big drivers toward your complexity. So Farlex describes it as a concomitant but unrelated pathological disease process, usually used in epidemiology to indicate the coexistence of two or more disease processes. The coding definition is condition which coexists in conjunction with another disease that is currently being treated at the time of the admission or develops subsequently, and it affects the management of patients' current consultant episode. What that means is it could be a chronic comorbidity that the patient came in the hospital with, or it could be just another condition that arose whilst they were an inpatient. It still counts as a comorbidity, and it's still relevant to be coded if it affected the management of the patient. So when we're coding, we use the whole medical record for that current inpatient stay. So we can read through all of the documentation within the dates of that stay, to make sure that all of the relevant comorbidities have been picked up, that were documented by the consultant. They have to be documented. We can't make assumptions, but we can read basically everything to find them. So here is a quick case study of the value of comorbidity recording, and we'll sort of take a look at what I've been mentioning about complexity. So if we look at the first column on the left, we've got a base HRG patient. So they come in and they've got cystitis. So it's a primary diagnosis. There's no comorbidities, no secondary diagnoses. So this is the HRG. If we get LA09Q, and you'll notice that the CC score is 0 to 2. So that's your comorbidity and complexity score. A base tariff there is £924 with a market forces factor uplift of £50. So market forces factors are designed to account for the fact that location plays a big part in costs. So in city centre trusts, you will get a higher market forces factor uplift to take into account the fact that running costs are higher, cost of living are higher, things like that. So in London in particular, the market forces factor uplifts are in the region of sort of 12%. 5% is what we've got in Manchester. In rural areas, it tends to be a little bit lower, and that is just added on to the base tariff. So we get a total price there of £974. But then if we go into the next tier, so it's also documented that the patient has anemia and they are recorded as being frail. So we've got these two comorbidities that get added. The HRG stays the same as that LA09, but the last character changes from a Q to a P. So we've gone to the next tier within that group, and that gives us a CC score of 3 to 5, and that's added almost £1,000 to the base tariff. Market forces goes up a little bit, and we get £1,800. So that's a big uplift just for those two comorbidities. But then again, if we look at the next tier, they were also noted to be hypokalemic and to have difficulty walking. Same HRG, but now the last character is N, and the CC score is 6 to 8. And that gets us nearly £3,000 plus £160 market forces. So the overall is just over £3,000. What's really important about this slide, and why I mentioned safe and sustainable care earlier, is this isn't a process of finding money down the back of the couch and saying, well, hey, we've scored a little bit extra. This is unrealised income. So all of these comorbidities could have been documented in a way that coders couldn't access. So it could have been left as a blood result that they had anemia and hypokalemia, but never actually documented that they represented the conditions. It could have been documented on a scoring index, but with no sort of qualifier that what the score related to, that they were frail. And the difficulty in walking could have been hidden away in a nursing note that wasn't filed correctly, and missed. It always was there. It always, because this information was always there, because these comorbidities always existed, this is always what it cost to treat the patient. It was always that £3,000 to treat the patient. They were always that poorly. If that information isn't documented in a way that coders can use and assign those appropriate codes, this is the value that will be achieved. This is the tariff that will be achieved. So then we have a problem with safe and sustainable care, because we're getting about a third of the price. We're only charging a third of the tariff, I should say, for treating a patient, and that isn't sustainable. So yeah, it's not an exercise in finding additional money. It's about unrealised income. It always cost this much, but we could only achieve this much if the information wasn't available for coders. And we've got a similar example with procedure coding. So this is what's called a TAVI procedure. It's an aortic valve implantation through a minimal access approach. So here the HRG is EY21B, and it has a CC score of 0 to 7. There's two tiers in this EY21B HRG. So with a 0 to 7 CC score, it's £8,000. The next tier will be a CC score of 8 plus, and that gets £10,000. So the overall score is £8,500. However, there's an alternate HRG which is very close to it, which also covers a TAVI procedure, EY220B. Same CC score parameters, so there's two tiers, a 0 to 7 CC and an 8 plus CC, but actually there's a £2,000 difference across the board. The only difference in the coding is this fourth character here on the secondary procedure. Oops, sorry. Is the fourth character on the secondary procedure. So the Y79.3 saying it's an approach through the femoral artery versus the Y79.4 saying it's an approach through the aortic artery. And this again highlights the importance of, one, really documenting clearly in procedure notes how a procedure was done, how that minimal access was achieved, but also the skill of a coder, making sure they get that information entered correctly and verifying the information correctly, because there's a lot of responsibility on that individual to make sure that the codes they enter are correct and there's no typing errors, because that could just be a simple typing error, and that can have a huge cost implication. And so it is really a complex process that coders are undertaking. So we've just talked quite a lot about comorbidities there. Would we say it's a reasonable assumption that long-term or permanent comorbidities should show a consistent pattern of coding across a patient's recent history, i.e., if a patient has diabetes, they should always have diabetes in their coded data set. It should always be present. You should always see it. You'd like to think it is a reasonable assumption. The reality is about 10% of admitted spells are identified as missing a comorbidity that we'd expect to be persistent and to have an impact on income. One of the sort of challenges that that we often have when we engage with clinicians on this point in particular is the rules that we're bound by as clinical coders. So we can, I touched on it in a previous slide, we can only use the information that's within that spell of care. So we're confined by the dates of the admission and the discharge. We can use every bit of information as long as it's in that admission dates. And clinicians will often push back and say, well, I documented it when that patient came in 2 months ago. They've come back to my care for the same issue. Why would I redocument the same things again? And we have to say, well, this is our national directive. We can't use that previous information. And there's a lot of clashing heads with coders and clinicians on that point. But what it comes down to is sort of what is the responsibility of who. So even though we have clinical in our title, so clinical coders, we're not clinically trained. We aren't clinicians, and we don't ever see the patients. We're just reading the information after the fact. So we can't know that it was documented correctly 2 months ago, and it was accurate. We also can't know that it's still relevant 2 months later. That's all clinical decisions that has to be given to us. That information needs to be provided by the clinical teams. If it was documented incorrectly 2 months ago and we just continued to document it, we'd have a consistently erroneous coded data set where errors are never sort of spotted and weeded out. So it's always an issue that comes up when we engage with clinicians, and it will continue to come up, but that's sort of one of the big drivers of why we end up with this sort of comorbidity discrepancy. So translating care with coders and clinicians, this is the challenge. So the research shows that coders are really quite good and effective at coding and entering the information, and the information that is provided by clinicians. But it's that information provided by the clinicians that can often be incomplete or unclear for coding purposes, and that is possibly the weak link in the data quality chain. We struggled with disengagement with clinicians for a long time, whether it was in the validation process of different data sets, or whether it was just disengagement from the process of coding and speaking to coders. Now that is from 2006. That's a really old sort of review. I would say since I've been involved in clinical engagement, it is much better. The clinicians who want to engage really want to engage. They really get it. They get the importance of it, and they will be vanguards for us in the clinical world. But there's a lot more clinicians that we don't reach, and finding a way to reach them, that is the real challenge, is trying to change long-standing habits and explain why they should be changed. And it's an ongoing battle. Things have got better, but it is an ongoing battle. So the big thing that we often talk about is an awareness of terminology, and so there's certain terms that coders can and can't use, so the list is, if you've got these modifiers against diagnoses, then we can assign the codes for those conditions, because they sort of indicate that something was done. It was assumed that condition was there, and treatment was given. We can't use these qualifiers. So you'll find this a lot. So impression is used an awful lot in diagnoses, and query, the little question mark, is used a lot by clinicians. We can't use those. So they indicate clinical uncertainty about the diagnosis. So we can't assign a code based on those terms. We'd only be able to assign the symptom codes. I mentioned test results earlier. So coders can't interpret test results because, again, we're not clinically trained. And some of them, sometimes you can think, well, that's ridiculous, because actually we all know that high BMI indicates obesity, and that's fine. But we don't all know whether a raised troponin level indicates angina or a heart attack, and what the differences would be and what the parameters would be. And it can't be that, well, we'll interpret some results but we won't interpret others, because then it just really muddies the water. So the flat line is, we can't interpret results. That responsibility has to stay with the clinicians. And to labour the point a little bit, we'll do another case study of exactly what I've been speaking about in the last few slides, about that information being there and the impact it can have. So this is a lady who, she fell over the dog in the garden, and she fractured. She recently had a knee replacement, and she had a fracture periprosthetic to that knee replacement. She had a infection while she was in hospital. Then she had a UTI that was just developed, that grew E. coli, and she had a scan. And we've got some comorbidities at the bottom. So she had a BMI of 34, long-standing EGFR levels of 45 to 59, and type 2 diabetes and osteoarthritis in the hips and knees. So the codes that we get are, if the page wants to load. So we've got our periprosthetic fracture caused by a trip, got our UTI caused by E. coli, we've got type 2 diabetes, and we've got the osteoarthritis, and then our CT scan. And that gets us an HRG with a tariff of £1,824. But the information that was missing was the BMI of 34 indicated obesity. The EGFR indicated CKD. Both of those conditions are codable. So in this example, we've added the two codes, and the tariff has gone up by over £1,000. So again, that information was always there. We could see that this information was there. The BMI of 34 was there. The EGFR level was there, but it wasn't in a format that coders could use. So to a clinician, it's obvious. To a coder, it isn't. And if it's not obvious to the coder, it can't be coded. And it only takes adding a word, obesity, CKD3, to then make it entirely viable to code. And they're quite important conditions that would have quite a big impact on patient care. So obesity could indicate the need for a specific type of bed for the patient to keep them comfortable. CKD would require monitoring of the kidneys. Certain drugs would be contraindicated because they'd be toxic to the kidneys. So capturing those two comorbidities in particular is really, really important, and that's why there's such a big implication in the tariff that's achieved, because they are quite important. But yeah, if they aren't documented clearly in a format that coders can use, they just can't be coded. And that's sort of where we get to with engaging with clinicians to make them understand that we can't decide what the answer is based on the result. You have to tell it to us. Legibility is always a big one. So like I said, we've just transitioned to an EPR, so this isn't so much of an issue anymore. We don't have to read the horrendous handwriting of doctors. And it is a running joke that doctors have really quite poor handwriting. And coders generally become very good at reading doctors' handwriting. It's one of the skills that you pick up. But that doesn't mean that you don't often get stupid. So here's an example of an endoscopy report that it's just illegible. It can't be used. If you were reading this, you can make out the odd word. You can maybe, a skilled coder could maybe figure out what's happened and get some codes in, but there is a high degree of likelihood that something will be missed in that, because you can't clearly see what's happening. So yeah, either substandard coding would result, or it would just have to get sent back and with a query saying, I can't read this. This is too poor. Contrast that with something digital. So we've got a really nicely typed operation note that's separated into different sections, and this goes alongside an anatomical diagram. So the coder can clearly see whereabouts things have been done, and they can reference the parts of the anatomy whilst they're reading the procedure itself. And that really helps with appropriate code selection, because you know to a very high degree that you're getting accurate codes, because there's no room for sort of misinterpretation when you've got documentation like that. So we can't not finish off with a really cheesy meme. So we've got teamwork. Together, each achieves more. So it's really easy to take what I've said in the last few slides and say, well, the onus here is on the clinicians. They've got to document better. Coders are great. Admin teams are great at what they do, but it's the impact of the clinicians that's causing issues, and that's not fair. It's the clinician's job to look after patients. Their primary focus is patient care and delivering life-saving care. It's our responsibility to engage with them and explain the importance of our roles and the importance of clear documentation in us achieving our roles, and why us achieving our roles makes their jobs easier and better, and what we achieve for them by doing our jobs correctly, and why we have to be able to work together, why what they do helps us help them. It can't just be a blame game. It has to be that two-way street of us working together. So that's the end of my presentation. Hopefully that's been helpful to you all and interesting in at least a little bit. That's my information, my details there. If anyone wants to get in touch with me, please feel free. Are there any questions? Please feel free to shout out. No, if there's no questions, then I'll hand back over to Becky.
Thank you very much. Oh, there is someone that has a question.
Oh,
they're still typing it.
That's okay, not a problem.
They're going to email you.
Oh,
It's going to take too much time.
Absolutely fine. Yeah, not a problem. Has anyone else got any questions? Conscious you might not all have microphones, so you might not be able to ask them, but if you do have a mic and you want to just ask it to the group, feel free. But if not, yeah, happy to take stuff via email.
If I can ask the question verbally, I could put one forward.
Oh, absolutely, yeah, absolutely. Please feel free.
Thank you very much for your presentation. It was very interesting, actually, and it's I am aware of what coders do in trusts. I think from my perspective, I work in a nuclear medicine department where we perform imaging procedures and non-imaging procedures, and we have what's called a RIS, a radiology information system. You mentioned a CT scan earlier. I imagine that department that performed that CT scan would have put a particular code against what they did. In nuclear medicine, there's not really any set of instructions on what particular codes to assign to a particular test. And in nuclear medicine, sometimes when you want to try and code things conscientiously to reflect your own activity in the department, to show your managers what you've been up to, but also you do want to make sure that the trust does get recognition for the work they've put into the patient. So, for example, let's say a patient's been referred for a bone scan. That's where we're looking for. Let's say they've got a suspicion of prostate cancer, and we're looking for an area in the bone which may have prostate cancer invaded into it. And we do the standard bone scan, and that has a particular code called it's called NBONW, NBONW. But when we look at the bone scan, we actually want to do some further scans. So there's a 3D scan that we can do, and a CT scan on top of that. And from my perspective, there's no real instructions at all on what particular codes to use. And I've spoke to some members in my community in nuclear medicine, and we're all doing things slightly differently, actually. And it does trouble me that, you know, in terms of coding, we want to make sure it's done correctly and accurately, but yet there's no set of instructions in my community for that. And I don't know how you feel about that from your perspective. I have written to our own coding people about it, and they didn't really explain it very well. They just sort of said, you can't keep adding codes, and if anyway, they all get sort of processed later on, and I think they go through one of your mincemeat machines that you showed anyway, and it just comes out as a single code. And the other thing as well that confused me is that if it was a bone scan as part of an inpatient, then it doesn't matter what we put, because I don't think it's included. It's mainly outpatients that the coding affects. Is that true? Or?
Yes, there's different parts of the answer to this. So the risk codes that you're talking about aren't the same as clinical codes.
Okay.
So that's kind of where I suppose your clinical coding team haven't been as helpful as they could be in giving you a clear answer. Because in terms of clinical coding, what they should have said is, don't worry too much, because when we get the information, we will assign the clinical codes, and what we'll look at is the text that you've put in and the text from the report to understand the scan that's taken place, rather than the risk code
okay,
that you've used. They'd be looking at the title of the scan and the sites that have been scanned and any nuclear materials that have been used in the scan, because they're the things that we've got codes to assign for. So where you can write text is where I'd say be comprehensive in saying exactly what you've done in text. In terms of, sorry, I've forgotten the other part of the answer I was going to give you. What was the other part of your question? Sorry.
Well, I think the other part was actually, it was more of a statement really, that I'm head of department, and no one's ever sat me down and said, right then, Joseph, this is how you code your studies. I mean, there's a set of national codes for nuclear medicine. There's a whole, I think there are primary codes and then secondary codes, but there's nothing there that says, right, you should be coding it this way for this test, or you know, this is the fair way of applying them. But actually, what you've just said to me has been quite a eureka moment, actually. If we put in, because I could see you were talking about looking at the reports, and you were looking at the patient information system to what's happened to patients. So if we get our doctors to report things a little bit more detailed, then that will be reflected in our activity. Or actually, for example, Sam, you know, we invest quite a lot of time and effort in our patients, and I do know that in some departments they don't put as much effort in. So, for example, in our department, we do the whole body scan and then the 3D images and the CT scan, but in some centres they don't have that ability to do it. But you know, it would be a little bit unfair if we got exactly the same amount of recognition or the same amount of finance payment for it.
And that's where the complexity of the codes assigned would, once you've got more codes to say, yes, we did the bone scan, but actually we added the 3D mapping and we did this, that, the other, that's where it starts to show that actually, no, this was a more complex scan than a DDH. Just remember the other part of the answer was to do with the outpatient setting. Radiology, interestingly, has quite a lot of national standards to sort of tell us how to assign codes. And there's you can almost split the chapter on scanning into two. So there's some that always need to be coded, whether a patient's inpatient or outpatient, and there are some nuclear medicine scans included on that. But then there's some scans that the national standard is you only code this in an outpatient setting, or if the patient was specifically admitted for it, and that's largely to do with it'd be expected that that kind of scan would happen for a patient with those diagnoses and comorbidities, so you wouldn't have to assign the scan code as well, because it would be bundled into that price. So the easiest example is that if a patient comes in with a fracture, it would be expected that they'd have an X-ray, so you don't need to code the X-ray in that scenario. But the list is quite clear of what you do code and what you don't code, and there are some nuclear imaging ones included. So like PET scans are always coded. But yeah, that's the difference between inpatient and outpatient.
Thanks, Sam. Thank you.
No problem. Any more? No? Okay, well, thank you all for joining today. And yeah, please do feel free to get in touch with me if you've got any further questions. I think the slides will be getting sent out after the session anyway, so you'll have my details on that last slide. More than happy to speak to people offline if you've got any questions or if you think of anything afterwards. Well, yeah, thank you all.